But thank you so much for taking the time to join us today. And so the first thing that we want to do is to create a safe learning environment. And this is normally an interactive face-to-face workshop. And so one of the reasons we do that is because it is such a serious topic. We don't want to trigger anyone. And so, you know, we need to be very sensitive to others' possible traumatic experiences. I do want to encourage people to engage in the chat box because this is, like I said, normally interactive. But please do so, you know, respectfully. And it's not mandatory, so that would be only if you choose to. And so I'm Jacquelyn Christmas. I have worked for the Missouri Department of Mental Health for 25 years. I started out working with individuals with developmental disabilities. And from there, I was doing some quality assurance. From there, I became an abuse neglect investigator, went to central office in Jefferson City, and then became the fatality review coordinator for the department. So I actually work for the chief medical director, Dr. Angeline Stanislaus is my supervisor. I am a certified question, persuade, and refer suicide prevention gatekeeper instructor. I'm a certified mental health recovery and wellness recovery action planning facilitator, and I'm a certified level 1 investigator. Also, I'm a member of the American Association of Suicidology, and I belong to the Impacted Family and Friends Division. I serve on the nominations committee for our board and also for the awards. I was recently appointed to the advisory panel for Johnny's Ambassadors. And this is interesting because I met this woman, this mother, through through the American Association of Suicidology, actually on a conference, a virtual conference, and we interacted in the chat box. And then we followed up with each other and realized we had much in common. And she had started this organization in memory of her son. And anyway, so I'm now on the advisory panel. I'm also involved with A Voice at the Table, which started in Massachusetts and is making its way around the country. We have a partnership or a collaboration with the American Association of Suicidology. I'm the Missouri coordinator for that. And what we do is we offer 2 what we call emotional wellness workshops. One is a re-energize and reconnect. And this is for individuals who either suicide loss survivors and suicide attempt survivors who are further along the path of healing. And then the second wellness workshop is the night, is for friends and family who currently have someone in suicidal crisis. And then finally, I'm a bereaved mother. This is my son. I'll tell you a little bit about my story. My son, Dustin, we just in August had the 8-year anniversary of his death. And he had a 10-year history of substance use. He was 27 when he died. He was an over-the-road truck driver. And I know that's scary to think, oh, he was a substance user and he was a truck driver. Yes, I know, very scary. But on this particular day, he was under the influence. He was in the passenger side. He was with his boss, and he decided to get out of the truck going down Interstate 40 right outside Vega, Texas. It's mile marker 36. You can see that's his roadside memorial. And so we didn't understand. We didn't know what happened. My mother, who's still living in 95, she had talked to him the night before and was concerned about his behavior and things that he was talking to her about. And she told me that he said he wasn't suicidal. Well, my mom's never been trained in QPR or anything else. And so, she wouldn't know to ask someone that. And so I wondered, how that even came up in conversation. Long story short, because we've got a lot of slides to get through, the medical examiner in Lubbock, Texas, ruled that it was an accident. I requested further investigation, which I wrote letters all the way up to the Attorney General's office. I didn't get any cooperation. I think they were just satisfied. Didn't want to spend any resources on a drug user, right? So anyway, I don't know. I don't know if my son died from accident. I don't know if he died from suicide. And then there was a time in my life when I had to accept that I would never know. And I'll weave more of my story in, as we go. Okay, first, I just want to engage you, get your brains going here. And if you would just jot it down maybe, or I guess you could even engage in the chat box if you'd like. But we'll have just these 5 questions, true or false. So number 1, there were more than 40,000 deaths by suicide in the United States in 2019. True or false? Number 2, if you ask someone about suicide, it could plant the idea in their head. Number 3, more men die by suicide than women. Number 4, guns account for over 50% of the mechanism used to die by suicide. And number 5, people who talk about suicide usually don't do it. And the answers are, yes, there were more than 45,000 deaths by suicide in the United States alone in 2019. And it's actually a myth, so it's false. If you ask someone about suicide, that you could plant the idea in their head. They're either thinking about it or they're not. More men die by suicide than women. This is true. And this is, really a public health crisis in that middle-aged men in rural areas are dying from suicide. Guns account for over 50%. Yes, that's true also. And we're going to go over some of the Missouri data here in a bit, and you'll see. People who talk about suicide usually don't do it. That's false. In fact, most people have dropped a hint, has said something in the days or weeks prior to their attempt on their life. And then I want to just make sure we understand what lived experience is, because that's a word that we hear a lot now, right? So traditionally, we have thought about attempt survivors and loss survivors, being those folks who have that lived experience. But over the last 2 or 3 years, and actually this was in response to a publication called The Way Forward, is that we've identified this group of impacted family and friends. And so those are individuals who are being impacted by a non-fatal suicidal crisis of a loved one. And that could be your teenage son, your spouse, a coworker, whomever, but that person is having suicidal thoughts, actions, and you're trying to support them. You're a loved one, you're a family or a friend, and it takes such an emotional toll. And so we've worked, A Voice at the Table has worked with the American Association of Suicidology, plus there were other publications from national experts that we know now that these are all groups that we need to be supporting. And so this is the 2018 data, that is the national data. I don't have 19 yet. I do for Missouri. But as you can see, there were over 48,000 deaths attributed to suicide. And that over the years, it's just, consistently gone up. And then this just kind of helps bring things, into focus. But if you think about it, there's a suicide every 11 minutes, or approximately 132 suicides every day in the United States. Our young people, age 15 to 24, over 6,000 died by suicide. And so that was a rate of 1 every 2 hours of our young people. And then suicide is considered a leading cause of death. I have to clarify because I am the fatality review coordinator. Technically, suicide's not a cause of death, it's a manner of death. But to be able to, collect the data and report it in this way, that's why they do that. So a cause of death would be, a gunshot wound, to the head, asphyxiation from hanging, poisoning by overdose. Those would actually be the causes, but we put all that together and say, well, those are suicide. So it does land at the 10th leading cause of death. So up until recently, most of us are going to die from heart disease, cancers, those kinds of things. Just because this is the time we live in, I will say that COVID for 2020 is now the 3rd leading cause of death. And then I want to draw your attention to the fact that homicide ranks 16th. And so the difference in numbers there, the first time I saw that, it was just staggering. I mean, who would have thought, So we hear about gun violence, and don't we always think about the homicides, when actually, there's so many, and I'm not saying all those were guns. Homicide can happen in lots of ways, but just so that you understand, in the United States, we have many, many more suicides than homicides. And then our national ranking, and we have not improved much from 2017. We were around 16, I believe, but we've moved down to this 12th spot. And we usually stop and have a lengthy conversation here about if you're looking at the top 2 or 3, and then you look at the bottom 2 or 3, why do you think that is? And, if anybody wants to unmute themselves and engage, that would be great. Or you're welcome to put something in the chat box. I've got my phone here too. I'm going to try to track the chat box and do the presentation. And I think I have to let more people, oh no, I have chat, okay. So why do you think that is? You might have to let people in now, okay. Isolation, yes, absolutely. And there's not any one, factor. But what those states have in common for, say, New Mexico, Wyoming, and Alaska is the vastness, right? And that there's more land than people, and so people are isolated. But other factors might also include, and let's look here, right, rural areas are, that's why in other states, rural areas are so at risk. Yes, lack of healthcare practitioners, so, you know, access to services, those kinds of things. But, you know, and I've not been necessarily to these places. I've maybe driven through New Mexico, but like Wyoming, in particular, Montana, Idaho, you think of ranches, farming, maybe that kind of thing, where guns are very much a part of their culture. And so if we then look, you know, at the other side, Washington, D.C., New Jersey, New York, lots of people, probably more services, you know, just those, the exact opposite. And I do believe some states may have, or municipalities, towns may have more stringent, you know, gun laws in some of those areas as well. But so the United States total rate, and this is per 100,000, is 14.8. And so, you know, Missouri is landing here at 20.1. So we're well above what the average, what the United States rate is. Okay, and so our Missouri data, and like I said, I do have this for 2019, but as you can see, suicide is in the 9 spot instead of the 10 spot. And this happened from 18 to 19. And so we had held consistent with 10 over a number of years, which was the same as the national, but this year, unfortunately, we've gone down, you know. And I'll just, again, because I'm the fatality review coordinator, comment on accidents being number 3. And this is in part due to the opioid epidemic, although we have made great strides over the last couple of years. Okay, now I have this as a handout also, and so I guess I can send it to Billy or try to post it here in a minute, but I do have this as a handout for you. But so where we stand, oh, I'm going to check the chat. We've got 2 more. Access to guns, yes. We can email to the participants. Excellent. Okay. And so last year, over 1,000 Missourians died. You know, like I said, the rate continues to climb. Although the rates dropped a little between 18 and 19, but it still put us at the 9th leading cause of death. So there was this glimmer of hope, and then it was, you know, like, it is the 2nd leading cause of death among our young people, 10 to 17, and more than 60% are firearms related. Okay, yeah, okay. So if you would like copies, type your email below, and then we'll make sure that you get everything. And then this is what is just staggering to me. 75% of those who die by suicide in Missouri are white males. However, the greatest decrease in that year was among Black males. And like you mentioned, like we talked about, rural areas in Missouri have slightly higher suicide rates than the metropolis. And then the differences in rural and urban suicide rates are less compared to the prior year. Thoughts and attempts, rates are highest among the 25 to 60-year-old group. 60% of all suicides involve firearms, And then you can see followed by, you know, suffocation, and so on. Okay. Okay, the data in Missouri by age, race, and sex or gender, they did decrease slightly among all age groups. However, the highest rate was among adults 25 to 64. It says youth rates in 14 were much lower, increased than the older age groups, and then increased and then leveled off. Suicides are consistently higher among whites. Suicide among blacks increased between 2015 and 2018, but then began to decrease again. And that suicides are consistently higher among males than females. Okay, the mechanism. So how they die by suicide. 60% in Missouri used firearms, and that's gone up from the time I've been involved in suicide prevention. You know, it was like 50-50, and then it was 52%, and so it just kind of, you know, steadily risen, but now we're at 60%. And you know, there's some thinking around males being more likely to use a firearm than females, although we are seeing some changes in this. And if you talk with the veterans or service member organizations, you know, we have a lot more women now involved in the National Guard or in the service. And, you know, I live in rural Missouri. We have women who like to go hunting. I mean, they'll shoot a deer just like that, you know. So, you know, so as women become more comfortable with firearms, you know, then I think could see that increase. And firearm-related suicides increase with age. So the older you are, the more likely you are, I guess, to use the gun. And then our poisoning, our overdose poisoning deaths have decreased by almost 5% since 15. And what we know, and there needs to be more research, is this intersection of substance use and suicide, like with my son. And so sometimes we wonder, was that really an overdose, you know, or was that a suicide, or the other way around? We call it a suicide when actually maybe it was an accidental overdose, but we do know that there is an intersection. All right, so the timing, which I think I already did this one right. I guess I thought it was really important if I put it in there twice. One suicide every 11 minutes or 129 every day. Okay, let's talk about the impact of suicide. And so Dr. Julie Searle at the University of Kentucky has done some research. It's actually recently been updated. And so the findings are even more staggering than these. But her original research says that for a single suicide, that 147 people are exposed. And of those, 53 have a short-term disruption of life, 25 have a major life disruption, and 11 are devastated, right? So family members, you know, mom, dad, siblings, grandparents, aunts, uncles, friends, you know, you can easily see how 11 people are devastated. And then if you work outside, you know, that person's circle of, you know, influence. So, you know, let's say they were a student, an adolescent at a high school, you know, you can see how that many people can be exposed and impacted, you know, in some way. And so for those of us who have been impacted or exposed to a suicide, for example, we know that in children, they are more likely, they're at greater risk if they're a survivor of suicide loss. And so then if you do the math, if the 47,000 Americans die by suicide every year, and then, you think about 11 people being absolutely devastated by that, it's mind-boggling. And if we think then, research used to tell us that if there was, for every suicide, there were maybe 25 attempts. And this is that impacted family and friends group I'm talking about, right? So it was a non-fatal suicide crisis. It was an attempt. But if that many people were impacted, we're looking at 30 million people in the United States that have been impacted in some way by suicide. Okay. And so if, again, looking at the math, if we take those numbers, then we're looking at, 1,400 people every day who are devastated by suicide. Okay, what was Missouri's response? Oh gosh, Missouri's been doing suicide prevention for a long time. We currently have 3 grants. The first grant is the one that's been around the longest. And it's you may have heard of them before, the Garrett Lee Smith or the GLS grants, which targets young people, youth. And it wasn't until 2018 that the first grant for providing services to adults became available. And then most recently, the third grant is specifically related to COVID. And so Stacy Williams is our state suicide prevention coordinator. That is her contact information if you ever needed to reach out to her. The Zero Suicide Initiative, and I was involved with this in the very early stages. In 2014, they had the first Zero Suicide Academy in Washington, D.C., and states could apply to attend. And so Missouri did that, and we were one of, I don't remember, 16, 17 states that were selected. And so the chief medical director at that time, Dr. Lane Young Walker, and myself, and then someone from a provider agency, we all went to DC to attend the academy. And at that time, it was really a national movement that was beginning, and we got to be a part of that. And so we were the first state to have all of our community behavioral health care centers trained in the zero suicide philosophy. Zero suicide is about, it's for health, including behavioral health, of course. It's for that level of, systems of care. And so now it was such a successful model that they are looking to adapt it to other systems like schools and workplace and such. But the original initiative was specifically geared for health and behavioral health care providers, of setting a bold goal of making, suicide a never event. For those of you familiar with the hospital lingo. So, and then Missouri also, since the last 5 years, let's say, has passed some legislation making it mandatory for certain educators and professionals, not mental health. I'm sorry, I just saw my typo. Must have been listening to some metal music or something. But mental health professionals that are required then to have some level of training in suicide prevention. For those of us who went to school a long time ago, decades ago, we didn't receive any training specific to suicide prevention. I'm, glad to hear now that others are, that younger people, that the social work departments, the psychology departments, they recognize now that it's really a specific subtopic, of mental health. And then through the grants, we started the Missouri Suicide Prevention Network. And I'm going to give you all of these links at the end. Okay, quiet. Someone says quiet riot. Thank you. Oh, goodness. Okay. And then, well, I was going to try this, another video, but I guess I won't. Or, okay. All right, so QPR. QPR is not intended to be a form of counseling or treatment. It's intended to offer hope through a positive action. And so the first thing I want to do is go over some of the myths and facts. And these are myths I grew up with. Like I said, I graduated my undergrad in 1982, and so had no training. But the myth is that no one can stop a suicide. It's just inevitable. That's not true. The fact is, if people are in crisis and get the help they need, they will probably never be suicidal again. And I like to use Kevin Hines as an example, and I hope that many of you have heard of him or even heard him, because he's been to Missouri many times. And I actually think he's here this month, but I don't know where. But Kevin's book, Cracked, Not Broken, which I have a copy of right here. And he says, I hope you like the book. Best, Kevin Hines. So this came first, and then the documentary, Suicide, the Ripple Effect. But Kevin's story is he was a young man enrolled in college, and he had a suicidal event. He jumped from the Golden Gate Bridge and actually survived to tell his story. And so it's a fascinating story, and I would encourage you to read up on it. You can Google him. He and his wife, Margaret, now have a foundation. He's a fierce mental health advocate, but he says, I won't die by suicide. He may have attempted that once, but he will do, and he still struggles. He has, we all have to take care of our mental health, right? And so, but he says, that's not how I'll die. And then another myth, confronting a person about suicide will only make them angry and increase their risk. Well, that's not true. The fact is, if you ask someone directly, it lowers their anxiety, it opens up some communication, and actually lowers the risk of an impulsive act, because some of these suicides are impulsive. And I like to use, everybody's named Kevin, and I apologize for that, but it's just how it happened. But Kevin Berthea and Kevin Briggs, and I've got his book. He has written this book. It's called Guardian of the Golden Gate Bridge. He was a highway patrolman. He's retired now, and that was his beat. And I've never been there, and so I don't I have nothing to compare it to, but that's what he worked, the bridge area. And so he had to learn real fast how to deal with suicidal folks. So on this day, Kevin Berthia is standing on that very thin railing in crisis. His wife had just given birth to preemie. He didn't know how he was going to pay the hospital bills, other stressors in his life. A young man also was not diagnosed, later found to have a diagnosis of depression. But he says, I was convinced I was going to hurl myself off, but he heard Kevin Briggs' voice and it made him stop and grab the railings. And that's what you see. They were up there for 92 minutes and it's cold, it's windy. I mean, you can see he's just got a short sleeve t-shirt and he's not hanging on to the railings. He's hugging himself and leaning in a little. Balanced, barely balanced, on that rail. But after a 92-minute conversation where the young man standing on the outside there said he spoke for most of that time and the highway patrolman just listened, and then he was able to come back over. He changed his mind. And so we know then that talking about it, asking someone directly can definitely lower the risk. And then here was their reunion 10 years later. And Kevin Berthia said he just kind of put it out of his mind that had even happened, that he had even done that, And then it was the American Foundation for Suicide Prevention wanted to give Kevin Briggs an award for the work he had done as a highway patrolman. And they reached out to Kevin Berthia and asked if he would present the award. And they became fast friends. They speak together. They travel around the country and do things together. They do things independently as well. They both have their own nonprofit organizations. It's a success story. Another myth is that only experts can prevent suicide. And the fact is it's everybody's business and anyone can help prevent the tragedy. And truth be told, if you were feeling suicidal, it's probably more likely that someone would stop it. Even if let's say you see a counselor on a regular basis, what's to say that, maybe you go once a week, once every 2 weeks, you may not be having your suicidal crisis on the day that you're seeing your therapist, and so it's going to be someone And so for all of us, we need to learn, as much as we can so that we can recognize these signs and help our loved ones. And so another myth is that suicidal people keep their plans to themselves. Most people communicate their intent sometime during the week preceding their attempt. And we had an acquaintance of my husband's that went and put his will, did his final arrangements. And nobody really thought, that much about it because of his age, and I'm saying you get up around, in your 50s, 60s, you start thinking about, I don't want to leave the financial burden for my family, blah, blah, blah. So you go take care of it. So nobody really thought anything of it. But in a way, that was in a way him communicating. But, and we'll talk more about that, what the kinds of things that people might say or do. is communicating their intent. And then there are those who talk about, the myth is those who talk about it don't do it. And this was kind of how I was trained, and not very well, shall I add, was that, oh, they are just attention seeking, you know, people who are talking about it, they just want the attention, and it's the ones who don't talk about it, those are the ones you really got to worry about. Where in fact, people who talk about suicide may try or even complete an act of self-destruction. And then sometimes in groups, we have conversations about, well, what if it is? I mean, what if we know that person, you know, is attention seeking? And then we say, well, why? You know, what is it that's missing in their life that they would need to do that? So, you know, behavior is communication. And so, so we need to listen. Another myth, once a person decides to complete it, there's nothing anyone can do. You know, we say, although this can be painful to loss survivors, and there's currently a conversation about not using this anymore, but we say it's a preventable kind of death, and almost any positive action, you know, may save a life. So we often talk about preventable deaths, foreseeable deaths, predictable deaths, you know, those kinds of things. And but some suicides, like I said earlier, are impulsive. All right, so now we're going to talk about the warning signs and what QPR calls clues. And so the more clues or warning signs that are observed, the greater the risk. So you want to take all of them seriously. And so first is those direct verbal clues. You know, I've decided to kill myself. I wish I were dead. I'm going to commit suicide. And I'll apologize because we really don't use that terminology anymore. We say died by. But this was a direct quote of what someone said, and that's why it's here. Or I'm going to end it all. Or if I don't get that big promotion, you know, if something doesn't happen, I'm going to kill myself. So it's very direct, and there's no question in your mind what their intent is, what they've told you. Then we have those more indirect or coded verbal clues. And this is where someone might say, I'm just tired. I'm tired of life and I can't go on. Or my family would be better off without me. Or who cares if I'm dead anyway? You know, nobody would miss me. I just want out. Or, you know, I'm not going to be around much longer. You won't have to worry about me much longer. Those kinds of things. And so, you know, you might take pause, you know, and what did you just say? You know, that could be a clue. And then we have behavioral clues. So we've got verbal clues, both direct and indirect, and now behavioral clues. And so some people who have attempted will attempt again, not everyone. I'm not talking out of both sides of my mouth. You know, most people who attempt once don't, but there are those who do attempt. And so anybody with a previous attempt is considered more behaviorally, you know, at risk. Anyone acquiring a gun or stockpiling pills, you know, this would be a behavioral clue. And I tell a story where when I used to travel, right, when we all used to travel, and I was working in Jefferson City, I always stayed at the same hotel with a little restaurant next door that I could walk to. And I would usually go, no judgment here, right, judgment-free zone. I would go to the bar, have a drink, get some food to go. But I was talking to the bartender, and she was telling me about a friend of hers that she was really concerned about, and that he had just recently acquired a gun. And I mean, it was like she had not had this training, but she knew she was that in tune, you know, with who her friend was, and thought that that was odd behavior, coupled with that he had been kind of down and stuff. So we did, you know, QPR. I said, you know, you need to ask him if he's thinking about suicide. It was closed at 9 o'clock, so she was going to get off work and go find him and talk to him. And so I followed up with her the next day, and you know, she said they had a good talk and were able to talk, you know, about his depression and such, but that he had denied any suicidal thinking, and that the reason he had acquired the gun was because it was a payment for a service. He was a tattoo artist. Someone didn't have the money to pay, but said, hey, I've got this, you know, so it was a barter kind of thing. But, you know, good for her for paying attention, right? And now everybody who has this training is going to be, you know, have that same ability. Also, if someone has co-occurring depression, moodiness, hopelessness, you know, these could be behavioral clues. Putting personal affairs in order. I use the example of the acquaintance of my husband's, or giving away prized possessions. And since I do fatality review, I do see these cases, and we did have a consumer who gave her little dog away the day before she jumped from an overpass. A sudden interest or disinterest in religion. Drug or alcohol abuse, or relapse after a significant period of, you know, sobriety. That can be devastating for folks. And so again, these are just clues. Unexplained anger, aggression, and irritability. So the more clues there are, you know, the more you would want to be thinking about, you know, I'm wondering if this person is thinking of suicide. And then situations that we find ourselves in, right? Sometimes beyond our control, that may actually put us at risk for suicidal thinking. And so one is like being fired or being expelled from school. I know I'm old, but I still have a college student. We took a lot of years having our family. And the pressure, you know, that these kids, I'm not saying that we put on them, but sometimes they put on themselves, you know, to perform and be perfectionists. And it's just can be devastating. A recent unwanted move, any loss of a major relationship. So whether that's, you know, a death or divorce, or, you know, just a falling out, maybe with someone that you've had a major relationship with for a long time. The death of a spouse, child, or best friend, especially if by suicide. And this is where I do my full disclosure and let you know that that I found myself in a suicidal, having an experience at the 6-month anniversary of my son's death. And I left town, I left my family, I left town. I went to a small town in Arkansas, checked into a motel, and was thinking about suicide. I went to my favorite restaurant, and down there, it's Eureka Springs, Arkansas. It's like one of my favorite places to go, and we go several times a year usually. But this time I went by myself. I went to my favorite restaurant and was thinking about what to order for my last meal. I somehow got through the night. And so, you know, I recall thinking about my other kids. You know, the reason I wanted to die was that I wanted to go be with my son. I wanted to see my son again. And then I, you know, remembered you have 2 other children. You have, you know, a husband of now 28 years. You have grandchildren. You know, for that one reason I wanted to die, I had so many more reasons, you know, to live. So, but that is a situation that can absolutely bring you to your knees. And then a diagnosis of a serious or terminal illness. And, this is not a conversation about, assisted suicide or anything like that, but, people who have a new diagnosis, or not even a new diagnosis, maybe they've been dealing with a serious or terminal illness for a number of years, or months or whatever, and may decide, that they would rather die by suicide than suffer or be a burden to their family. It's more often than not worried about being a burden to others. Also, the sudden, unexpected loss of freedom, fear of punishment. And so we do serve forensic population. We have inpatient facilities or state-operated programs for individuals who've been found, not guilty by reason of insanity or other things. So that loss of freedom, fear of punishment is very real. We have had suicides in our own facilities. We have had situations where we've had folks come in for an evaluation and then maybe had to go back to the county jail and then died that afternoon, that day, same day, in one particular case, where then he was able to find a ligature and hang himself in the county jail. Anticipated loss of financial security is another one, and I have to laugh. The last time I asked this question, a young person answered, but I talk about, the Great Depression, and she thought I was talking about like the 2008. And I was like, no, I'm sorry. I'm talking about the real one, so, but, if you remember from your history, people who, when the stock market crashed, there were suicides. And so it was related to that loss of financial security. I wonder with our aging population, we know that men aged 85 and over are the ones at greatest risk. Here they've been, good providers, so, there's retirement, there's other kinds of job loss, especially now in COVID, right? So that loss of financial security is very burdensome for folks. Also, a loss of a cherished therapist, counselor, or teacher. Some people, maybe their only connection, is with their favorite teacher at school, or, maybe they've had the same therapist for 10 years. And case managers, and the work that we do, and maybe some of you do too, where people get attached to staff that they work with and such. And then, of course, that fear of becoming a burden to others. And if you're interested in knowing more about some of the theories behind suicidal behavior, Dr. Thomas Joyner, with a J, at the University of Florida, has a model that talks about hopelessness and burdensomeness and those kinds of things. Okay, so now we're going to talk about how to ask someone if they're thinking about suicide. And so the first tip is that if you're in doubt, don't wait, ask the question. Wouldn't you rather go ahead and do that than worry, oh gosh, I should have, shoulda, coulda, woulda, kind of thing, and if the person's reluctant, you can be a little persistent, always make sure you're talking to that person in a private setting also. This is not the kind of conversation that you're going to want to have in the lunchroom. allowing that person to talk freely, just like Kevin Briggs allowed Kevin Berthea to talk for like 89 minutes of those 92. So you have to have plenty of time. You know, if this is a training that you're taking for your job, you know, you don't want to start a conversation 15 minutes before your shift is over, right? I mean, you don't know how long someone is going to need, and you need to be there for them. Have your resources ready. And so, you know, normally in a face-to-face training, I have a little booklet for you that has, you know, a card that pulls out, but, you know, you can make your own card. You can, whatever county you're in, there should be a community behavioral health care center or a crisis line. In fact, that's something else I should have is the Access Crisis Intervention programs across Missouri. And so I'll send that to you as well, Billy and others, so that you'll have that. But remember, how you ask the question is less important, you know, than that you ask it. Because people can be, you know, it's a touchy subject, and we're very uncomfortable talking about it. It's taking, you know, I mean, I'm not, but I've been doing this for quite a while, but I understand, you know, I understand how some people feel. And so you can take a less direct approach. You can ask them something about, you know, have you been unhappy? You know, has that unhappiness caused you, you know, to think that about ending your life? Or do you wish that you could go to sleep and never wake up? I was a young social worker in the late 80s and 90s in a hospital, and always responded to, we were on call, always responded to the emergency room to talk to folks who had come in with suicide attempts. And like I said, I had never had any training. I asked them if they were thinking about harming themselves. And, you know, I'm not saying that's not okay, but for some people that might mean, you know, something completely different. So, I mean, to ask someone directly, are you thinking about taking your life? Are you thinking about suicide? You know, is best. And so a direct approach, you know, when people are as upset as you seem to be, they sometimes wish they were dead. I'm wondering if you're feeling that way too. Or you look pretty miserable. And one of the videos I talked about a misery index. So, because people go, well, gosh, that's kind of a weird thing to say. You look miserable. But, you know, I'm wondering if you think about suicide. But if you think about it, you know when people are miserable. You can tell by looking. I've had people come up to me and say, are you okay? You're just off. And I'll, no, I'm not. I'm having a bad day, you know. So, but, you know, if you can ask them, are you thinking of taking your life? Are you thinking of killing yourself? Are you thinking of suicide? If you can't, find someone, you know, who can. You know, so it's okay. Not everybody is comfortable with this. So if you can't, find someone who can. Here's how not to ask the suicide question. You're not thinking of killing yourself, are you? Well, you wouldn't do anything stupid like that. Well, that's dumb. You know, I mean, those are what we would call, you know, you're not thinking of killing yourself, are you? That's a leading question, you know, and so we never ask those, you know. You are basically telling them the answer you want to hear, which then they would say, no, man, I'm not, you know. So, and then how do you persuade someone? You know, how do you persuade someone to go get the help that they need when they're at the lowest point in their life? You got to listen to the problem and give them your full attention. suicide's not the problem. It's, we've heard this for years, right? It's this perceived, solution, but it's really not. You don't rush to judgment either. It's hard, and I understand that, because someone's problem may not seem that significant to you, but for them it is. And so I like to give the example of, your first love in high school or whatever, because we do have our youth that, after doing a psychological autopsy, you find that it was a breakup with a girlfriend, boyfriend, and you think, oh my gosh, well, that's a stupid reason to do it. But you know what? That's their first love. They don't have anything else to compare it to. So you kind of have to put yourself in that person's place and remember what it was like to be, 16 and in love and dumped and humiliated in front of your friends, and, however the scenario goes. As adults, we might go, well, get a clue, kid. Well, no, you get a clue, mom, dad, teacher. These are the most, serious problems that they're having in their worlds. But the key is to offer hope in whatever form that is, because that's how we save people, is through hope. So you might ask them, will you go with me to get help? Or will you let me help you get help? Will you not kill yourself until we've found, some help? And so just your willingness to listen and to help, it can really make all the difference in the world. It can rekindle hope that someone cares about me. Someone wants to listen to me. And so any engagement it can have a positive influence. So how do you refer people? People often believe they can't be helped, right? I've been in that dark place. We probably know people who've been in that dark place, that there's no help for me. It's just a hopeless situation. The best referral involves taking someone, taking the person directly somewhere where they can get some help. And so this is when you might, if they're agreeable, call the crisis line. And in some of our bigger communities, they have mobile crisis, where they'll go out to the person. The next best referral is just getting a commitment, kind of a good faith commitment from them that they're going to accept help, and then helping make those arrangements. So maybe helping make an appointment or whatever. And then the third best referral is just giving them some referral information. And, and again, that good faith commitment that they're not going to attempt. Any willingness to accept help at some point in time, even in the future, is a good outcome. So if you've ever tried to hand someone your business card and they don't want it, you know what I'm talking about. If they take that information from you, if they say, I'm not ready now, I don't want to do it today, but if they take that information from you and put it in their purse or their wallet, that is a good outcome. Because I know people worry. Well, what if, should I call the police? Should I take him to the hospital? That's a whole different topic, a different training. But research shows people are at higher risk of suicide after they leave the hospital. We're not doing people any favors by hospitalizing them because they're having suicidal thinking. And so, so if they'll take that information, that's good. So remember, almost all efforts to persuade someone will be met with some type of relief and possibly agreement. So don't hesitate to get involved, and maybe even take the lead. It's just really about being a decent human, right? saying, I want you to live. I'm on your side. We'll get through this. I remember back in my hospital days and having to like hotline, child abuse. I never left their side, and I just explained everything that was going to happen and that I was there to help them get through it. And so get others involved. Is there someone that you want me to call that can help? A family member, a friend, maybe a pastor, priest, rabbi, maybe a doctor, maybe a therapist, but you can also ask, who do I need to call? Who can help you? So when you apply QPR, you plant the seeds of hope, and hope helps prevent suicide. And this is the QPR Institute website. And so I would encourage you, if you want to know more information, you can find it there. Okay, now I've added a few things that Billy and I didn't really talk about, but one is suicide grief. I thought it was appropriate on World Suicide Prevention Day that we talk a little bit about suicide grief. And so, of course, the loss is someone significant to the meaning, of that person's life. And then, suicides are usually sudden, unexpected, and traumatic. But then, as if that's not bad enough, right? Then society as a whole has been unwilling to try to understand the pain and uniqueness of suicide grief. And culture has dictated that person made a choice, And so those are the kinds of things that for the bereaved of suicide loss, they're dealing with the society's attitudes, and whatever culture that they're in. And some cultures are very not dismissive, what's the right word? Well, I'm thinking of like where the people, pastors might say suicide's a sin, and that's kind of historically how it's been, although we've worked with the faith community for, a number of years and bringing them along that understanding that it's not, that there are other factors and, blah, blah, blah. So the faith communities are more and more understanding of how it is that people die by suicide. And then it sets people up for what's called complicated grief. And so what that means is that those symptoms of grief will be especially difficult because of the sudden violent, those deaths are traumatic. I relived that, that's on there, replay and reconsider the circumstances of the death with my son, and thinking about when he got out of that truck and the few seconds that it took for him to hit the ground and break his neck, and, all the gory details. I played that over again and again and again, hoping that it was, I can't imagine, I just, 8 seconds, 10 seconds, I don't know how much time he had to realize, I don't know. So yeah, we replay that stuff over and over again. And just the loss of that significant person in your life, it's overwhelming. And so other risk factors for complicated grief, again, it's unexpected violence, such as a death even from a car accident, a murder, or a suicide. My son's cousin was a homicide victim just a few years after Dustin died. He had been one of Dustin's pallbearers, and he was shot in a road rage incident here in Joplin, Missouri. And then for us bereaved mothers, the death of a child sets us up for complicated grief. And it doesn't really matter how. My brother I lost my niece on January 1st of 2020. She was 20. She had pulmonary hypertension. She was diagnosed when she was 10 years old. So she had been a sick kid. You know, she was a Make-A-Wish kid. They got to go, you know, to Disney and stuff. But I guarantee you that their pain is just as significant and real as a homicide, a suicide, you know, an accident. When you lose a child, you know, it is the worst day of your life. A closer dependent relationship to the deceased person, you know, so a spouse, a sibling, that's a risk factor for complicated grief. A lack of a support system or friendships. I mean, we have to have support. And that's, you know, I reach out when I find out in my community, in my circle of influence, if of a death, doesn't have to be a suicide, just a death. I reach out to the mother and offer condolences and provide resources, and you know, because I know a lot of people are uncomfortable just with death, period, and being able to go to someone and say, "I'm so sorry for your loss." You know, that's really it. That's all you have to say. People say, "I don't know what to say. I'm so," you know. So anyway, okay, then a past history of depression or other mental health issues. So that would make you a higher risk for complicated grief, or if you had any traumatic childhood experiences such as abuse or neglect. So if you're familiar with ACEs, adverse childhood events, you know, that would make you more at risk. Also, you know, some people just have more resiliency than others. So if it's a person that lacks resilience or the ability to adapt to life changes, then they're going to be at risk. And any other major life stressors going on. So like, what about COVID, right? Talk about major life stress. So, you know, all of these deaths that we're dealing with right now through COVID kind of puts us at higher risk. You know, we've not been able maybe to attend funerals. That happened early on. A friend of mine's father passed, and that was when early, like March, they said only 10 people can come. And she said, our family's bigger than 10 people, you know, to have the service. And she said, like, we showed up, we guess we broke the law. But so, you know, those kinds of issues. And then I want to touch on this Dr. Alan Wolfelt, and I've got this resource for you too with the Center for Loss and Life Transition. This is my go-to on grief. And he writes, he does have work specific to suicide grief, but just in general, the 6 needs of mourning is acknowledge the reality of the death, embrace the pain of the loss, remember the person who died, develop a new self-identity, search for meaning, and then receiving support from others. And these are the needs. These have to be met. You know, acknowledging the reality of the death. This is a process, right? I mean, that shock and denial thing, we're built like that for a reason, and it's for, you know, protection, because we can only take you know, so much. So that early grief kind of, you know, you, like I would wake up every day, is this real? I don't understand. Even after Dustin was buried, and it took 6 days to get his body back from Texas. And so we were 8 days to the funeral. But even after he was buried, there was a time I went to the cemetery every day. And it was until that headstone was set that the reality, you know, kind of started sinking in for me. So, and embracing the pain, oh gosh, how do you do that, right? In Western civilization, we don't want to feel pain. We don't want to work through things, you know, so, but you have to dose yourself. Remembering the person who died, you know, this is ongoing for me. Of course, he was my son. It's called continuing bonds. I'm still his mother. I visit the cemetery monthly. I take whatever holiday we're having. Like I went this week and took, fall flowers and that kind of thing. I'll take Halloween, whatever holiday it is, I decorate. Developing a new self-identity, so suddenly I found myself a bereaved mother. And then searching for meaning. So you search for meaning not only in the death, but like in my case, where I had a son who was a substance user, that I would wonder what was the meaning of his life. Not just his death, but his 27 years of really not being particularly productive in terms of what I had hoped, for my child. So, searching for meaning and receiving support from others. I'm not going to read these. You'll get them, but this is the Mourner's Bill of Rights. And so I do want to just say, number one, you have the right to experience your own unique grief. And everybody experiences grief differently. Some people may privately grieve. This was a real issue for me with my 95-year-old mother. Now, she hasn't always been 95, right? But when her mother died, who was also in her 90s, my mom didn't cry. I didn't see her shed a tear. And I was like, well, that's kind of weird, but all right, And then, a few years passed, and then my dad died, and I did not see her shed a tear. When my son died, her grandson, and she did not shed a tear, I quite frankly was a little ticked off. But I had to understand that she has the right to experience her own unique grief, and that maybe she does it privately, or maybe she has other ways that she does it. And that's okay. Okay, so here's some grief. This is grief resources. This is, like I said, my go-to, the Center for Loss and Life Transition. These are a couple of his books that are specific to suicide grief, although he has books for all kinds of grief. Other resources in terms of suicide, the Suicide Prevention Resource Center, the American Association of Suicidology, the American Foundation for Suicide Prevention, and then the Lifeline. I've added Johnny's Ambassadors and A Voice at the Table, the two organizations that I'm involved with, I told you about earlier. So if you're interested in learning more, I do want to mention on Johnny's Ambassadors, this organization is a very narrow focus on something called dabbing, which nod your heads. Do you know what dabbing? Do most people know what dabbing is? I was a little naive, but it's a high THC content. It's smoked. It's like a waxy, oily. It has a special pipe that you smoke it through, but the THC content in it is like 90% plus over regular marijuana. So her son, Laura's son, Johnny, was dabbing and had a psychosis related to the high THC content, and jumped from a building six stories. Left a note. I mean, he was suicidal, but it was related to this psychosis from the dabbing. And so she is that's what her focus is to stop dabbing. And then we didn't talk a whole lot about lethal means. If you want to know more, the best place to go is this Means Matter website. And you can also take a free online course on counseling on access to lethal means. This is, about a little bit about what we talked about in terms of, are they stockpiling meds? Are they trying to secure a gun? Whatever because there are lots of different means, right? I just recently reviewed a death where the person put a plastic bag over their head and, you know, tied it off with a belt. And so, you know, means are all over the place. When we look at things happening within our hospitals and our state operated programs, you know, constantly looking at environmental risks, doing environmental risk assessments, and, you know, are there ligatures, and what can we do to minimize, you know, those risks. And then I liked this, you know, we all experience our mental health differently, and that's okay. Listening to and supporting those who are struggling are powerful ways to help. Just being a listening ear is powerful. Check back with them, offer to connect them to the help that they need, and don't underestimate the impact that you can make, you know, in encouraging someone on their mental health journey. So that's kind of like what to do. Then I was going to show another video on what not to do. So, but I got to tell you about it, and then you can Google it. It's Bob Newhart, if y'all know the comedian Bob Newhart, and it's called Stop It. And so this is a comedy. It's 6 minutes of him playing the therapist. And anyway, that I recommend it highly, but that would be the what not to do. He's a terrible therapist. And then what to do is to instill hope, right? However you can, is to instill hope. Today, as we've talked about, is World Suicide Prevention Day. And so I would like to invite you to light a candle at 8 p.m. this evening and put it near a window where it can be seen from the road to show your support for suicide prevention. Do not put it so close that you catch your curtains on fire, though. So be very mindful of that. We actually had a Facebook event started that we would all connect tonight, you know, at 8. So, you know, let your friends know. Light a candle tonight at 8 to show your support. And then it's walk season, people. I've got to talk about walk season. So I just found out about walk season about 3 or 4 years ago. So the first year I did 3 walks. Let me think, last year I did 2. And then this year I'm the chairperson for the Joplin Walk. But this is through the American Foundation for Suicide Prevention, and they have the Out of the Darkness walks. Well, because of COVID, we're all working on doing hybrid events. So we'll have virtual events, little pop-up events, and every community is doing their own thing, and then we're coming together and also doing some stuff. So in fact, we'll be putting out a video today sometime. But here's where your Missouri walks are, and that is the link to sign up or donate or, you know, whatever. But I would encourage you to get involved if you can. And so walk season goes through, you can actually donate through the end of December, but it officially kicks off in September. And so our first walk is this Saturday. Again, the QPR Institute, this is me and my contact information. Okay.
All right.
Well, everyone, thank you again for taking the time. All right. Appreciate it.